Okay, let's unpack this. We're delving into something, well, pretty remarkable and honestly quite disturbing in biology.
Hmm.
It's the slow process where normal body tissues actually start to harden, almost turn to stone in a way.
Yeah.
We're doing a deep dive into pathologic calcification and really focusing today on what happens when the body's whole mineral balance just goes completely off the rails.
It's really the ultimate sign that something systemic is deeply wrong. We're talking about abnormal deposits of calcium salts, though. Often there's iron and magnesium mixed in, too,
Right.
depositing outside the skeleton where they shouldn't be. And understanding this, especially what drives it, gives you this crucial window into major metabolic problems happening inside.
Now, when most people hear calcification, they probably think of, getting older, maybe hardening in a scar, or perhaps plaques in arteries.
That's right. And those generally fall under what we call dystrophic calcification.
Okay, so that's different.
Totally different context. Dystrophic calcification is strictly localized. It's calcium salts depositing only in tissue that's already dying or damaged.
Like old injuries.
Exactly. Think of an old scar, or the cheesy necrosis you see in TB, or maybe heart valves that have been roughed up by inflammation over years.
Okay.
But the key thing here, the really critical distinction you have to remember, is that the person's overall mineral metabolism is fine, their blood calcium, perfectly normal. The problem is just in that specific damaged spot.
Got it. But our main focus today, our mission, is the other type, the one that's systemic and, frankly, much more worrying. Metastatic calcification, or MC.
Yes, MC. It's fundamentally different because the defining feature is calcium salts depositing in otherwise normal, healthy tissues.
Healthy tissues turning hard.
Precisely. And the absolute critical point, the single engine driving this whole process, is that it almost always stems directly from hypercalcemia.
Meaning too much calcium in the blood.
Abnormally, pathologically high levels of calcium circulating everywhere.
So if we start seeing, say, lung tissue or the stomach lining calcifying, that calcification itself isn't the root problem.
Not at all. It's the telltale sign. This is a big flashing warning light indicating a major upstream crisis in how the body is handling calcium. A metabolic SOS, if you will.
Right. So seeing that means you have to look beyond the organ itself.
Exactly. That's the essential aha moment for anyone learning this, or for clinicians. You see MC, you immediately start focusing on local damage and start hunting for the systemic cause, the hypercalcemia.
Okay.
Metastatic calcification is essentially a map showing you where this flood of excess systemic calcium decides to settle out. Our goal today is to trace that flood back to its main sources. There are about 4 or 5 key ones.
All right, let's get into the mechanics then. The hypercalcemia itself,
Yeah.
that engine driving MC, you said it can't happen without sustained high calcium. So where does all this extra calcium come from? What are the big sources?
Well, keeping calcium levels steady is one of the tightest balancing acts the body performs. Calcium is vital for nerves, muscles,
Right, everything.
everything. So when that balance fails, it's usually down to one of 4 main kinds of metabolic disturbance that push serum calcium dangerously high. And these link conditions as different as cancer and kidney failure. It's quite fascinating.
Okay, let's take them one by one. What's the first major cause? You mentioned endocrine issues earlier.
Yeah, the classic one is excess parathyroid hormone, or PTH.
PTH, okay.
PTH is basically the commander-in-chief of calcium. Its job is to keep blood calcium up no matter what. It tells the kidneys to hang on to calcium and dump phosphate. It works with vitamin D to boost absorption from your food.
But the main action is bone.
The fastest way it raises calcium is by telling bone cells, specifically the osteoclasts, to start dissolving bone tissue.
Breaking down the skeleton to release calcium.
Exactly. So if you have too much PTH, the textbook example is primary hyperparathyroidism, usually caused by an overactive gland, maybe a benign tumor called an adenoma,
Right.
that puts bone breakdown into overdrive, releasing lots of calcium.
And how does that usually show up? Is it sudden?
Primary hyperparathyroidism is often a slow burn. The hypercalcemia might creep up over years. Patients might just feel off, vague symptoms. There's that old mnemonic, stones, bones, groans, and psychic moans.
Kidney stones, bone pain, gut issues, and mental fogginess.
That's the one. It hints at the slow, multi-system effects.
Yeah.
And the metastatic calcification in this case tends to build up gradually, too.
But you also mentioned cancer can mimic this. That sounds faster.
Oh, much faster, and clinically very important.
Yeah.
This is called humoral hypercalcemia of malignancy, or HHM.
Okay.
Certain cancers, especially squamous cell lung cancer, kidney cancer, some head and neck tumors, They start pumping out a molecule called PTH-related protein, or PTHRP.
PTH-related protein.
Yeah, and it's an almost perfect mimic of actual PTH. It binds to the exact same receptors on bone and kidney cells.
So the body thinks it's getting a massive PTH signal.
Exactly. It triggers incredibly rapid and severe bone destruction. This can cause a hypercalcemic crisis really quickly, leading to fast metastatic calcification. It's a much more aggressive scenario than the slow-growing parathyroid tumor, a really dangerous link between cancer and mineral balance.
Whoa. Okay, so that's PTH driving bone breakdown. What's cause number 2? You said breakdown can happen without PTH involvement.
Right. Number 2 is increased bone resorption that's independent of PTH. Here, it's not about the hormone signals. It's about direct physical destruction of the bone itself.
Physical destruction?
Yeah, the sheer amount of bone being destroyed overwhelms the body's ability to clear the released calcium.
What kind of things cause that level of destruction?
The classic examples are cancers in the bone marrow. Think of multiple myeloma.
Plasma cell cancer, right?
Exactly. These cancer cells grow in the marrow and release substances, cytokines, that directly tell the local osteoclast to just chew up the bone. Leads to those characteristic punched-out lesions you see on x-rays. That mobilizes huge amounts of calcium very quickly. You also see it with widespread, diffuse skeletal metastasis when cancers like breast or prostate spread extensively to the bones. The sheer volume of bone being lost can cause hypercalcemia that's really hard to treat.
That sounds pretty severe. Are there less dramatic causes too? Non-cancer related? You mentioned lifestyle factors.
Yeah, even something seemingly simple, like prolonged immobilization.
Just being bedridden.
Exactly. If someone's completely laid up, the skeleton isn't getting the normal mechanical stress it needs. That lack of loading shifts the balance towards bone breakdown.
Really?
Yep. The calcium release isn't usually as extreme as with aggressive cancer, but it can definitely be sustained enough, particularly in kids or people with already high bone turnover, to cause chronic hypercalcemia and contribute to MC over time. It just underscores how important movement is for keeping minerals balanced.
That's fascinating. Okay, cause number 3. You mentioned vitamin D. That seems counterintuitive. Isn't vitamin D good for bones?
It is, but it's all about balance.
Ellie.
Cause 3 is vitamin D-related disorders. Vitamin D's main job is to crank up calcium absorption from your gut.
So too much vitamin D means too much calcium getting absorbed.
Precisely. You get way too much active vitamin D, you create this huge, uncontrolled flood of calcium coming in from your diet, leading to overload.
And how does that happen, besides someone just taking way too many supplements, which I guess is vitamin D intoxication?
Right, intoxication is one way. But the really interesting non-intoxication example is sarcoidosis.
Sarcoidosis, the inflammatory disease with granulomas.
That's the one. It often affects the lungs, skin, lymph nodes. It forms these collections of immune cells called granulomas. And the key thing is the macrophages, the immune cells within those granulomas, develop this abnormal ability.
What ability?
They start converting the precursor form of vitamin D, 25-hydroxyvitamin D, into the super potent active form, 1025-dihydroxyvitamin D. And they do it completely outside the normal control systems.
So it's unregulated production of active vitamin D by these immune cells, bypassing the kidney and PTH feedback loop.
Exactly. It's ectopic production. It happens where it shouldn't, and the body can't shut it off easily. This leads to massive calcium absorption from the gut, causing hypercalcemia. It's a totally different mechanism than PTH excess and needs different treatment.
Any other vitamin D-related causes?
Well, there are rare conditions like idiopathic hypercalcemia of infancy, sometimes linked to Williams syndrome. Essentially, an abnormal sensitivity to vitamin D causing serious calcium issues very early in life.
Okay. Now for the 4th big one, you said this is maybe the most common driver today, linked to chronic disease.
Yes. Number 4, chronic renal failure or chronic kidney disease, CKD.
Kidney failure, how does that lead to too much calcium? I thought kidney failure sometimes caused low calcium.
It can initially, but it sets off this complex destructive cascade. It's central to what we call CKD mineral bone disorder, or CKD-MBD.
Okay, break down that cascade for us.
It starts with the kidneys failing to do one of their key jobs, getting rid of phosphate. So phosphate levels in the blood start to rise. Phosphate retention.
Right.
Now think of your blood like a glass of water. It can only hold so much dissolved calcium and phosphate before they start, well, crashing out together. There's a limit. The solubility product.
Like putting too much salt in water, it just settles at the bottom.
Exactly like that. High phosphate threatens to exceed that limit. So the body makes a quick adjustment. It slightly lowers the amount of free active calcium circulating, trying to prevent widespread precipitation.
Okay, so phosphate goes up, free calcium dips slightly,
And that dip is detected by the parathyroid glands.
which, as we learned, hate low calcium.
They panic. This triggers a massive compensatory response called secondary hyperparathyroidism. The glands go into overdrive, churning out enormous amounts of PTH.
Trying to raise calcium by breaking down bone.
Exactly. But now the patient is caught in this vicious cycle. High phosphate causes low free calcium, which causes sky-high PTH, which chews up the skeleton, releasing calcium, often pushing the total calcium level way up into the hypercalcemic range.
Oh, wow. So you end up with high phosphate and high calcium?
Often, yes. The calcium phosphate product gets dangerously high anyway, despite the body's initial attempt to lower calcium, and this leads to widespread calcification.
And the kidneys themselves get hit.
Tragically, yes.
Yeah.
The failing kidney, which started the whole mess, becomes a prime target for calcification. That's called nephrocalcinosis. It damages the kidney even further, worsening the failure, driving more phosphate retention, more PTH. It's a perfect storm.
A truly vicious cycle.
Yeah.
You also mentioned a couple of less common, more specific causes?
Right, just to be complete. Things like aluminum intoxication, which was more common back when dialysis fluid sometimes contained aluminum. It messes with bone metabolism and PTH, leading to hypercalcemia. And the historical curiosity, milk alkali syndrome. Basically, people taking huge amounts of calcium, often from milk, plus absorbable antacids like Tums, calcium carbonate. It just overwhelms the kidney's ability to excrete calcium.
Right, overloading the system.
Exactly. Leads to hypercalcemia and metabolic alkalosis.
Yeah.
That's common now with better antacids, but still seen occasionally.
Okay, so we've established the engine, sustained high calcium, driven by these four main culprits, plus a couple of others. Now, the localization mystery. If the whole bloodstream is full of excess calcium, why does it pick on just certain tissues? You mentioned lungs, kidneys, stomach. Why them and not, say, muscle or brain?
This is where the biochemistry gets really neat in a grim sort of way. It's the alkaline trap.
The alkaline trap. Okay.
It is absolutely not random. Metastatic calcification has preferred targets. The interstitial tissues of the gastric mucosa, stomach lining, the kidneys, the lungs, systemic arteries, and pulmonary veins.
A very specific list. What do they all have in common?
The key insight, the unifying factor, is that all these tissues are actively involved in excreting acid.
Acid excretion. That's the link. How does that create a trap?
Okay, think about it. Your blood plasma is carefully buffered around pH 7.4, right? Stable.
Right.
But locally, in the tiny spaces around the cells, in these organs that are actively pumping out acid, things are different. Take the stomach lining, pumping out hydrochloric acid into the stomach lumen.
Okay.
Or the kidneys managing acid-base balance. Or the lungs constantly getting rid of CO2, which forms carbonic acid. As they push acid out into the stomach, into the urine, into the air, the interstitial fluid immediately behind those cells becomes slightly more alkaline.
So maybe pH 7.5, 7.6 locally, just for a moment.
Exactly. Maybe even a bit higher in some spots.
Yeah.
And that slight shift towards alkalinity dramatically lowers the solubility of calcium phosphate.
Ah, I see. So if the blood is already supersaturated with calcium and phosphate because of hypercalcemia?
That little local pocket of alkalinity is the perfect trigger. It's the spot where the calcium phosphate says, okay, I can't stay dissolved anymore. And it precipitates, it crashes out of solution right there into the normal tissue.
The tissue's own function, getting rid of acid, makes it vulnerable.
Precisely. The acid excretion creates an internal alkaline compartment, setting the trap. The kidney's a prime example, constantly managing ions. The lungs, exhaling CO2. The stomach lining.
Pumping out acid and leaving bicarbonate behind.
Exactly. Pumping bicarbonate into the interstitial space makes it alkaline. It's a beautiful, terrible piece of chemical logic.
That explains the why them. So what does this actually look like if you could see or feel it?
Macroscopically, looking at the organ itself, the deposits can range from fine, white, gritty granules, almost like sand, to really dense, chalky clumps. An organ heavily affected can apparently feel quite literally gritty or even stone-like.
Wow. And under the microscope, what does the pathologist see?
On the standard H&E stain, the calcium salts grab onto the hematoxylin dye, so they show up as intensely basophilic, deep blue or purple.
Okay.
They usually look kind of amorphous, maybe granular, clumpy. They deposit in the connective tissue between cells, on basement membranes, sometimes even inside the cells themselves.
Is it just like random mineral dust, or does it organize?
It can start as amorphous, non-crystalline stuff, but often, over time, it matures and crystallizes into hydroxyapatite.
Hydroxyapatite, that's the same mineral that's in normal bone.
Exactly the same. And in some really chronic, severe cases, the body might even react by trying to form actual bone around these deposits. It's called heterotopic bone formation, literally. Bone growing in the wrong place like the lung or stomach. Bizarre and disastrous outcome.
Bone in the lungs. Okay. So moving on to the clinical side, does this always cause problems, or can you have these deposits without noticing?
That's a key point. Often, especially if the deposits are small or scattered, MC can be clinically silent for a while. The body has reserve capacity.
But when it gets bad,
When it becomes massive, it's a very high-stakes situation. You start putting rock into vital organs, you get critical consequences.
where's the most immediate danger, typically?
Probably the lungs. Massive MC in the lungs gives these really dramatic X-rays, sometimes called a snowstorm appearance.
Yeah.
But the functional impact is serious. The calcium stiffens the alveolar walls, the tiny air sacs, and the blood vessels in the lungs.
Making it hard to breathe.
Exactly. It reduces the elasticity, the stretchiness the lungs need. This leads to significant respiratory compromise, a type of restrictive lung disease. Gas exchange gets badly impaired.
Okay, lungs are a major risk. What about the kidneys? You mentioned nephrocalcinosis.
Yes, the kidney is caught in that terrible double bind. Massive calcium deposits in the kidney tissue itself. Nephrocalcinosis physically damages the nephrons.
The filtering units.
Right. The deposits can clog the tubules. They trigger chronic inflammation. They lead to scarring. It progressively destroys kidney function, causing permanent, irreversible renal damage.
Worsening the very problem that might have caused the MC in the first place?
Precisely that cruel feedback loop we talked about. Kidney failure causes MC. MC then destroys more kidney function. It just accelerates the whole decline.
And you mentioned arteries and veins, too.
Yeah, MC often targets the walls of systemic arteries and pulmonary veins. This contributes to vascular stiffness, makes vessels less compliant, which can worsen hypertension and overall cardiovascular strain.
This brings us back nicely to dystrophic calcification, the kind in damaged tissue. How does having high systemic calcium hypercalcemia affect that process?
This is the force multiplier effect. It's really important. Remember, dystrophic calcification happens in damaged tissue even when blood calcium is normal.
Okay.
But now, imagine a patient who also has systemic hypercalcemia, maybe from their kidney disease or a parathyroid problem, and they already have some underlying tissue damage, maybe some atherosclerosis, maybe a slightly damaged heart valve.
Right, common issues.
That high level of calcium floating around in their blood dramatically accelerates the dystrophic calcification in those already vulnerable spots.
So the hypercalcemia acts like fuel on the fire for hardening arteries or valves.
Exactly. Atherosclerotic plaques calcify faster and become more brittle. Damaged heart valves stiffen up much more quickly and severely. It pushes patients towards needing interventions like valve replacements sooner. So metastatic calcification isn't just creating new deposits, it's actively worsening common age-related cardiovascular damage too.
That's a really crucial interaction. Okay, this whole picture sounds pretty grim, especially thinking about chronic kidney disease affecting so many people. What's being done? What are the modern approaches to managing this, to preventing MC?
Yeah, thankfully we've moved way beyond just chasing the calcium number after the fact. Modern management of CKD mineral bone disorder is much more sophisticated. It's a multi-pronged attack targeting the key players: calcium, phosphate, and PTH.
You said phosphate buildup in CKD is often the first domino, so tackling phosphate must be key.
Absolutely foundational. Aggressively targeting phosphate is job number one in CKD patients at risk. This is where phosphate binders come in.
Binders, what do they do?
They're medications patients take with meals. They're not absorbed themselves, but they grab onto the phosphate from the food right there in the gut.
Okay.
They form an insoluble complex, basically locking up the phosphate so it passes out in the stool instead of getting absorbed into the bloodstream.
Preventing the initial phosphate overload, are all binders the same?
No. There's been significant evolution. Older binders were often calcium-based, like calcium carbonate or calcium acetate. They worked, but they added to the calcium load, potentially worsening hypercalcemia.
Right, trading one problem for another.
Sort of. But the newer generation binders, like sevelamer or lanthanum, are non-calcium-based. They bind phosphate effectively without adding extra calcium to the system. That's a huge advantage in breaking the cycle and reducing the risk of MC.
Okay, so that helps control the phosphate. But what about the runaway PTH, the secondary hyperparathyroidism that chews up bone? How do you control that without messing up calcium even more?
That's where some clever pharmacology comes in, specifically drugs called calcimimetics.
Calcimimetics, mimicking calcium. How?
They target a receptor on the surface of the parathyroid gland cells. It's called the calcium sensing receptor, or KSR. This receptor is how the gland normally tastes the blood calcium level.
Okay.
Low calcium, the KSR is quiet, PTH gets released. High calcium, the KSR is activated, PTH secretion is suppressed. Calcimimetics, like a drug called cinacalcet, bind to this KSR.
And what do they do there?
They essentially make the receptor more sensitive to the calcium that's already there. They sort of trick the gland into thinking the calcium level is higher than it really is.
Ah, so the gland dials back PTH production.
Exactly. It suppresses PTH secretion. And this is brilliant because you lower the destructive PTH levels without having to actually raise the patient's blood calcium, which would just fuel the MC. It breaks that vicious cycle of secondary hyperparathyroidism in a targeted way.
That's clever. So you're managing phosphate intake and you're managing the PTH response.
Right, it's a multi-vector approach. Plus, we have better imaging techniques now. Things like advanced CT scans can help detect calcification earlier, especially in blood vessels. There's ongoing work to better distinguish the metastatic type from the dystrophic type.
And early detection means earlier intervention.
Precisely. Catching it before it causes irreversible organ damage like severe lung stiffening or end-stage nephrocalcinosis. It really underscores that treating MC isn't just about the deposit. It's about managing the entire complex mineral balance systemically.
Okay, so let's try and synthesize this deep dive. Metastatic calcification. It's basically the body's chemistry demonstrating, quite tragically, what happens when systemic illness messes up the mineral balance.
You know, whether it's cancer, a parathyroid problem, vitamin D issues, or very commonly now, chronic kidney failure.
And the formula seems to be way too much calcium in the blood, combined with these specific tissues that create little alkaline pockets.
Equals mineral depositing, or it absolutely shouldn't, in normal, healthy tissue. That alkaline trap mechanism, targeting organs that excrete acid like the lungs, stomach, kidneys. It's a stark illustration of physiology going wrong.
And while it might be silent initially if it gets extensive, it can literally turn parts of vital organs into stone, leading to devastating outcomes like respiratory failure or kidney destruction.
And we can't forget, it also turbocharges common age-related damage in arteries and heart valves.
Right, the force multiplier effect.
If you step back and look at the bigger picture, MNC really highlights just how delicate mineral homeostasis is. The body needs calcium. It's essential. But it walks this incredibly fine line. Too little is bad, but too much. Too much leads to this slow, insidious petrification from within.
That tightrope analogy really works. Which leads us to a final thought, something for you, the listener, to consider, connecting back to something we touched on earlier.
Yeah, we mentioned that prolonged immobilization, just not moving, can cause bone loss, hypercalcemia, and thus increase the risk for MC.
Right.
So it makes you think about the flip side. How crucial is regular physical activity? Not just for keeping your bones strong in the usual sense, but for maintaining the stability of that huge calcium reservoir in your skeleton. Preventing uncontrolled breakdown might be critical for protecting all your other soft tissues from the systemic mineral imbalance. Maybe skeletal health, driven by activity, is truly central to preventing the rest of the body from hardening. Something to ponder.